wabarakatuh. And good morning, ladies and gentlemen. Welcome to the online visiting lecture today. First, let me introduce myself. My name is Jumiatul Adawiyah. I will be responsible for hosting this event today. And I am very glad to welcome Professor Gangli from Department of Oral and Maxillofacial Radiology, Peking University School and Hospital of Stomatology. As our present today, good morning, Professor. How are you today, Prof?
Yeah, thanks you.
The Honorable, the Dean and Vice Dean of Faculty of Dentistry, Universitas Pajajaran, the Head of Study Program Dental Maxillofacial Radiology, Universitas Pajajaran. Good morning, Professor Soharjo. Good morning, Professor Hana. Good morning, Professor Barunawati. And good morning, Dr. Gigi Harisutianto. And all the lecture staff and the residency students from all major in Faculty of Dentistry, Universitas Pajajaran, and all the participants. Ladies and gentlemen, now I would like to inform you about the rundown today. The first session is word from Head of Study Program, Dental Maxillofacial Radiology, Universitas Pajajaran. The second session will be the welcome speech and opening from Dean of Faculty of Dentistry, Universitas Pajajaran. The third session is lecture presentation from Professor Gangli and followed by discussion session. The last session will be certificate submission, photo session, and closing. Ladies and gentlemen, before we start the event today, let us pray according to our beliefs for the event to be successful. Let's pray. Well, next agenda is the words from Heads of Study Program, Dental Maxillofacial Radiology, Universitas Pajajaran, Dr. Ashari PhD, Specialist Consultant of Dental Maxillofacial Radiology. Dr. Ashari, time is yours.
Okay. Thank you, Dr. Jumiatun. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. The Honorable, our visiting Professor, Prof. Gangli from Peking University School and Hospital Stomatology, the Honorable, the Dean of Faculty of Dentistry, Universitas Pajajaran, which all the Vice Dean, the Honorable, all the lecturer, staff, and all the participants. All praise to Allah for His guidance and blessing today. Prayers and peace be upon our Prophet Muhammad SAW. It's a real pleasure for me to welcome you at this online visiting lecture today about application of CT and MRI in oral and maxillofacial radiology that will be delivered by our visiting professor, Prof. Gangli. Honorary ladies and gentlemen, Universitas Pajajaran is currently pursuing a number of goals in order to become a world-class university. This is the reason why we need to improve the quality of learning and research in higher education, and also to develop our capacity to compete in the global higher education through the acquisition and creation of advanced knowledge. One of strategy approach for developing its goal, it has an international reputation for its teaching and learning process. Joining visiting lecture would improve the quality of the teaching process and contribute to providing an international education perspective for students. The audience for this visiting lecture is teaching staff and resident students from various major at Faculty of Dentistry, Universitas Pajajaran. I'm hoping that the information present in this present will be well accepted because it's directly relevant to our area of expertise. The imaging subject is relevant not only to oral and maxillofacial radiology, but also to another resident program. I would like to take this opportunity to thank all of the chairperson, committee members, and the speaker, Prof. Gangli. Thank you for the Dean of Faculty of Dentistry, Universitas Pajajaran, who have granted the committee an honor for sitting and conducting this visiting lecture. I sincerely hope you will enjoy the lecture. Thank you very much for your attending. Assalamualaikum warahmatullahi wabarakatuh.
Thank you. Thank you.
Thank you very much, Dr. Ashari. Now we move the next agenda. The welcome speech and opening from the Vice Dean on behalf of the Dean of Faculty of Dentistry, Universitas Pajajaran, Dr. Dudi Arifin, Dr. Gigi, Spesialis Konservasi Gigi, Subspesialis Konservasi Restorasi, Konsultan. Dr. Dudi, time is yours.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Thank you, MC, for the time and also the opportunity for me to convey a few words of welcome to our lecture today. Welcome, I say to Honorable our lecturer, Prof. Gangli from Peking University School and Hospital of Stomatology. Thank you for your willingness to fulfill our invitation as a lecturer in this visiting professor activity. And also thank you to all the participants, Prof. Suharjo, Prof. Hana, Prof. Barunawati, and also Dr. Haris, and all the lecturers and residents from the Faculty of Dentistry, Pajajaran University, and also all the residents from other university. Thank you for coming.
Terima kasih, Mas.
Thank you.
Thank you.
Currently,
Thank you,
our
Mas.
university is preparing to become a world-class university, WCU, and this activity is one of our current targets. We hope that our cooperation would be continued. Before we get started, I would like to express my appreciation to the head of specialist program, Dentomaxillofacial Radiology Department, Dr. Azhari, DRG MS, SPRKG Consultant, and all the committee who generously helped us make this visiting lecturer come true. We could not have done it without you all. In today's visiting lecturer, we will learn about application of CT and MRI in oral and maxillofacial radiology. I hope this lecturer will give you a new experience and new knowledge. Without lingering, I open this lecture and enjoy it. Thank you. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, MC.
Thank you very much, Dr. Dudi. And now we move the lecture session that will be guided by Dr. Belisam as moderator. Now I will read the curriculum vitae of Dr. Belly. 1998 graduate from dentistry profession at the Faculty of Dentistry, Universitas Pajajaran. 2008 Magister Main Study of Oral Biology, Postgraduate Program, Universitas Pajajaran. 2012 Oral and Maxillofacial Radiology at the Faculty of Dentistry, Universitas Pajajaran. 2014 Consolidation National Values for the Indonesian Medical Council, Lemhanas Republik Indonesia. 2015 Forensic Dentistry and Forensic Anthropology. 2019 Advanced Digital Dental Imaging Course, cover Finland, University and Beveridge, Munich, German. 2021 Doctoral of Medical Science Program, Faculty of Medicine, Universitas Pajajaran. Work experience 2003 until 2040, Secretary General of the Executive Board of the Indonesian Dental Radiology Association. 2017 until 2018, member of P3 KGB, Commission Executive Board of the Indonesian Dentist Association. 2019, Director of Academy and Medical Service for Dental and Oral Hospital, Universitas Pajajaran. Well, Dr. Belli, we will have 60 minutes for the presentation of Professor Gangli and also 30 minutes for discussion session. For all the participants, you can put your question in the chat windows, or if you want to deliver your question directly, you can click the raise hand button out once the discussion session is opened by moderator. Please keep your microphone unmute while the presentation. Dr. Bali, I leave this session to you.
Okay, thank you, Jumiato. Okay, good morning, ladies and gentlemen. The Honorable Dean of Faculty of Dentistry, Pajajaran University, Dr. Dudi. The Honorable Head of Specialist of the MFR Academic Program of Faculty of Dentistry, Pajajaran University, Dr. Asari. The Honorable all Professor and Prof. Soeharjo System too. And the Honorable the Head of IKARGI and the FFR Collegium, Prof. Hana and Dr. Haris. And of course, all the participants. First, let us thank to Almighty Allah Subhanahu wa Taala, because of His blessing we are able to come here to join this event. The visiting lecture from our amazing professor in DFFR Radiology from Peking University of School and Hospital of Stomatology, Prof. Gangli. Yeah. Good morning, Prof. Gangli.
Hi. Good morning.
Okay. Same as President Joko Widodo. Jokowi, our president, who has a special call for Chinese President Xi Jinping.
Yeah.
Jokowi calls Xi Jinping Big Brother. Yeah, same as that. May I call you Big Brother Gangli? Yeah, Bailey Gangli. Yeah, same. Okay, Dr. Gangli is the professor of Oral and Maxillofacial Radiology at Peking University, School and Hospital of Stomatology. He obtained his DDS degree in 1993 and worked as a general dentist for more than 6 years. In 1999, he went to Stockholm, Sweden, and studied in Karolinska Institute, where he got his PhD degree in 2004. And since then, he did his postdoc work at AXA, Amsterdam, yeah, the Netherlands, until 2007, when he came back to China. Dr. Gangli is currently one member of Standing Committee and Secretary to China's Society of Oral and Maxillofacial Radiology, founder member of European Academy of Dental Maxillofacial Radiology, and fellow of International College of Dentists. He has authored more than 80 peer-review articles and been an editorial board member for 7 international peer-reviewed journals. Since 2011, he served as an associated editor for the Journal of Dental Maxillofacial Radiology and official journal of International Association of Dentomaxillofacial Radiology, EADMFR. Okay, ladies and gentlemen, the presentation today is about application of CT and MRI in oral and maxillofacial radiology. Okay, same morning in Bandung or Indonesia, Prof. Gangli in the Peking.
Yeah.
Okay. Apa kabar? And glad to see you in this event. You have 50 minutes for present your slides, and after that we will continue to discussion with our audience. Okay.
Yeah.
Okay. Prof. Gangli. My big brother, time is yours.
Thank you for your nice introduction to me. And also, I have to say good morning, everyone there. And it was my bigger pleasure to be here with you to talk about the radiology, dental radiology here. And as you know, today I will talk about the application of CT and MRI in oral and maxillofacial radiology. There are three main parts of my presentation. The first one is about a brief introduction to CT and MRI imaging so that you can have a brief review of these modalities. And the second part is the brief review for the basic principles for image interpretation, which I have already given last year, but I would like to give a reminder about this very short. And the third part is the clinical cases captured by CT and MRI imaging and interpretation on it. So, cone beam computed tomography was invented in 1972 by Godfrey Hounsfield. I think everybody knows it. At that time, it was called computerized axial transverse scanning because it is only slide scanning. At that time, we used the fine beam and the linear detector, and at each time only can scan one layer of the body, so get only one slice of images. So at that time, you have the concept about the box size, but with different thickness. You know, the thickness is not the same as the pixel size. But also you have the thickness between two layers, so that makes the lesions smaller than the thickness between the two layers omitted. Sometimes people just because it is not imaged, so you cannot see it, so cannot make diagnosis for the lesions. So that is the drawback of this first generation of the CT. But after that, people invented spiral CT, which means that the scanner and the detector can rotate around the patient with the patient bed. Here is the patient bed moving forward, and that the detector and the machine rotate around the patient. So there is no thickness between slices, so they can reconstruct the images without the omitting of lesions there. So that is big advantages of this spiral CT. After that, about 1992, and people invent the multi-detector CT. That means use multi-detectors to get the images from the fine beam side field of the X-ray field, and then they make the images of the patient. Also, they use the spiral CT, the technique for that rotate the patient and then get the patient forward. So at quick time, they can get CT images. So this kind of CT images is very good for the heart imaging because the heart is beat quickly and cannot get a stable image if we use the first generation images. CT image can show us the soft tissue that is different from the CBCT. So from these images, that is X view, this coronal view of the CT and the second view of it, you can see clearly of the images of the muscles, that lateral pterygoid muscle, then there is the medial pterygoid muscle and masseter muscle. So very clear. Also, we can see a lesion. Here is a lesion, pharyngeal here in the pharyngeal space, there is a lesion, soft tissue lesions here. So it's very clear from the CT images because he can show the soft tissues. And another advantages of the CT is they can provide the CT numbers. They use the water as the references and use the tissues, linear attenuation of tissues to minus the linear attenuation of waters, and then divided by the linear attenuation of waters and multiply 1,000. That time, if we give this number is 1 here, that means if the water is the tissues, then they will give a number of 0. So the CT numbers or the CT values is just provided like this. The 0 is for water, and the air is minus 1,000 Hounsfield, and the dense bone is about 1,000 Hounsfield. So the unit of CT number is Hounsfield. Use a Hounsfield unit in order to memorize the inventor of Hounsfield. So you can see 0 is represent the water, and minus 1,000 HU represent the air, and the dense bone is the plus 1,000 HU. And also they can show the bone windows and the soft tissue windows by giving the window levels and the window width. So usually give the window levels at 500 HU and the width about 700. So that provide us the bone window images. If we gave the window level at 40 and the window width is about 4,000 and then 400, and then the images can be called soft tissue window images like this. So that is the difference from the Cone-beam CT images. Here, this table shows some typical Hounsfield unit for air and tissues. For bone, it's about from plus 4,000 to plus 1,000 HU. The soft tissues is the plus 40 to plus 80. The water is 0, and the fat is minus 60 to minus 100, and the air is the minus 1,000. Sometimes we got the fat numbers is above plus 10. So in my experience, sometimes not so low, sometimes you can get the fat CT values about 10. This is the plain CT image. That means without any injection of a medial contrast. So it can show the soft tissues. You can show the bone because here's the soft tissue windows. It seems like there is a lesions here, but you're not so sure because of artifacts from the dense bone and teeth. Then you can give the injection medial contrast into the body and get the so-called enhanced CT images. Then you can clearly see the lesions on the tongue, in the tongue. So the third advantage is, I think, the CTAs can be used for enhanced CT images to get more clear images, big contrast of the soft tissue lesions. So in general, CT can display soft tissues, can provide us CT values, which is most important for some lesions. I will show you later, and can be enhanced to provide enhanced images. Now we come to the general introduction to the MRI. Here is a general principle of how works of the MRI modalities. Here, because in our body, there are many hydrogen atoms, and these atoms randomly oriented in our body. And then they are put in an external magnetic field. All these hydrogen atoms will be aligned within the external magnetic field or against the external magnetic field. After getting some frequency, because the machine will relieve some radio frequency to the atoms. After getting some frequency atoms, radio frequency, that means the atoms get some energy. So they will leave this mean field and rotate upwards or downwards. So get this, and then get their energy trying to leave the mean field. After the release of the stop releasing of the radio frequency, the energy will be released from these atoms, and then the signals from these atoms will be received by the receiver here, receiver call, and then used for the reconstruction of the MRI imaging. So that is the general principle of the MRI imaging, how it works. Here is the machine, the photos of the machine, MRI. This part is the main part, can provide the external magnetic field and the radio frequency used to activate the atoms. There are two important concepts for the MR imaging. One is repetition time, PR time. That means the time between radio frequency passes. Another concept is echo time. That is the time for signal recovery. So we got these two most often used images. One is T1 weighted images. Another is T2 weighted images. T1 weighted images often obtained by using the TR, that means repeating time is 500 milliseconds, and the echo time is about 20 milliseconds. So in this way, we got the images can be used to show the high anatomical details, because in this images, the fight shows the high signal. So we also call this T1 weighted image is fight image. T2 image is obtained by using repeating time over 2000 milliseconds, and the echo time over than 60 milliseconds. This type of images is often called water images, because in this image, the water shows the high signal, very bright. And these images is often used for looking for inflammatory changes and tumors, because the inflammatory can release some blood in the tissues. Also, there are necrosis in the tumors. So sometimes we use these T2 weighted images to observe the infections. Here shows the example images of the T1 weighted images. So you can see here, that is the image of a temporomandibular joint. Here is the condyle here, and here is the disc. You can see the disc and also some soft tissues around him. And this one is T2 weighted images. Also for the TMG regions, but there's a high signal here. That means that there is inflammation in the back area of the joint. For the TMG observations, there's another very important series of MR images. We call it protein density images, PDR MRI. These images often obtained by using the repetition time 2000 to 5000 milliseconds. And the echo time is about 10 to 20 milliseconds. This is often used to look for the position of temporomandibular disc. Here shows the images of this 3-1. This is the PD weighted images. We can clearly see the disc, the anteriorly displayed temporomandibular disc here. Maybe someone will say, you can also see the disc in the T1 weighted image. Why did you, or does you show us this by the PD weighted images? Because now we use the very high magnet field machines. Often is 3.0 Tesla. So with the such high Tesla magnetic machines, the disk will only be shown in the PD weighted image, not in the T1 weighted image. So that is why we use the PD weighted series images to show the temporomandibular disc here. Okay, now just to finish this the introduction to the CT/MR images. Now the brief view of the law of interpretation of images. Last year, I have given a lecture about this, and I used the law of Lopez for the interpretation. Law is location, P is periphery in an internal structure, and S is surroundings. Location means the position, single or multiple focal lesions, and also the lesion size. Periphery, we often observe if the periphery is well-defined or ill-defined, because this is clearly related to the nature of the lesions. These images also show benign lesions, often shows the character of expanding, because there's very good, very well delineated borders you can see, and they give the nature of expanding and get the surrounding teeth or tissues displaced. So they can see the teeth is displaced. So this kind of nature of the lesion is benign. But we come to the malignant natures, you can see all the structure will be destructed. That means the destruction is the malignant lesions. So you can see all this bone is destructed. Also here for the osteosarcoma, the bone will be broken down, and also for this overlap of some peripheral actions of this to form a so-called Codman triangle. And also here is the same as spike-like the triangles. So spike-like a bone, sun bones here. So this kind of is the osteosarcoma also for this destruction of the bones to make the teeth floating in the bone. So these imaging features shows the lesions not good, maybe malignant. And then we have to observe the internal structures. It is totally radiolucent, or it totally radiopaque, or is a mixed density. So that's very useful for us to give a correct diagnosis. S Lopez, S represents surrounding, that means surrounding tissues, to analyze the effects of the lesions on surrounding structures. I will not give a brief, detailed explanation about this, but just to show you them, you have to be observe surrounding tissues as well. Then we come to the diagnostic tree. So from above the analysis, we form this diagnostic tree, and then we can get a relatively correct diagnosis. So the above is the brief review for the basic principle of image presentation. Okay, now I will show you the cases that captured by CT and MRI and the diagnosis and interpretation on it. The first case is a female. She was 60 years old when he came to our hospital. Her complaint, a heart super to the left posterior teeth that was without pain or swelling, and did not get any difficulties in the mouth opening. The medical history of the lesions is the mice was covered by chance. When the food particles became trapped in the space between the hard mass and the check. No history of trauma or inflammation to the area. So here are the images of the patient. You can see when we use the clinical examination, we can see the face is asymmetrical. It's not asymmetrical, it's asymmetrical. And then the mouth opened normally. So there's no limitations in mouth opening. And also we cannot palpate any enlarged lymph node in the area of submandible or gallus areas. Intraoral examinations shows a well-conscribed, movable, bony hard mass located at the backside of the maxillary left second premolar and extending to the anterior rim of the pterygomandibular fold. The mass was approximately 5.0 multiplied 1.0 centimeters in size and covered with normal oral mucosa. Results of blood and serum chemistry analysis were within the normal ranges. From these clinical examinations, we get an overview of the lesions and give us an impression this lesion is the benign or malignant. Yes, it is a malignant. It is a benign tumor expression. This is the good one, not the bad one. Then we can see that is the panoramic radiograph of the patient. We can see there are two mices, actually two mices here. And then we use this Lopez law to analyze the radiographs. So we can see one was in the anterior to the ramus of the mandible. One is here. And also we can see, seems there a capsule around the lesions. And the other was just super to the sigmoid notch and the choroid foci. Here, you can see here. If we look at the periphery of the lesions, we found this one is also well-defined. Seems there is a capsule around the lesions too. So these two lesions here are well-defined. And the internal structure, we can see it is radiopaque with some radiolucent dots, inside. And if see the surroundings from this panoramic radiograph, you can see that the posterior wall of the left maxillary sinus was deformed. That case was deformed inside. So when we take the CT images, we can clearly see the lesions there, just besides of the posterior wall of the maxillary sinus and before the ramus. Also the ramus was deformed. Okay, you can see the ramus was deformed here, and also the posterior fold was deformed by the lesions. Also there are two lesions here, two lesions there. There is bone window, soft tissue windows. So we can see there is no any soft tissue attachment to the surroundings. It is isolated. It is isolated lesions, not connected to the surrounding tissues. And also in the bone windows, we can clearly see this mice, the density of the mice is similar to the bone, the density of bone. And also inside is not homogeneous. You see a homogeneous, is there some dots here? With bone windows, there's a soft windows can show us exactly where and how the lesions relate to the other tissues. Here is the three-dimensional images from CT images. We can show here there's two mice here, one is here and one is here. And this are the specimen's images after operation. We got an image on it and see this is the one here in front one, the lesions here, and this is the lesions up here. So there's two lesions actually. What is that? From this diagnostic tree, what can you get for these lesions? So we can see it is acquired abnormalities, right? So cyst, no. Benign neoplasia, malignant neoplasia, inflammatory lesion, or just the bone dysplasia vascular. I don't think this part is related to all lesions, only this part. So after analyzing the above informations, and also we can see that it's well-defined borders and inhomogeneous inside and the same density to the bone here, to the bone, similar density to here. So we can give a diagnosis as bone benign neoplasia. And then the final pathological examination gave us on the osteoma. Because this one is very special. Osteoma is not rare. We can see it, but not in these places because this is in soft tissues. That is located in soft tissue of this osteoma. So that is unusual. And also it was in the pterygoid infratemporal fossa, infratemporal fossa. This area is not common. It's very rare to have osteoma in here. So that makes us sometimes cannot give a correct diagnosis. But anyway, this is a benign one. The final diagnosis is the osteoma. Now we come to the second case. This one is a male, 50 years old. He complained of mice in the right tongue for 3 months. When we checked the medical history of this patient, we found that the mice was discovered also by chance, and no changes in size after found date. Also, there's no pain, and there's no anything to influence the patients to talk, to chew, to swallow, or to open his mouth. When we make clinical examinations, we found round, smooth, and hard mice about 1.0 centimeter in diameter was in the lateral edge of the tongue. It has no exact borders and attached to the adjacent tissues. When you palpate the lesions, because it is very easy to see the lesions on tongue, you palpate the lesions, it is not good, immovable, and also attached to the deep tissues. The mucosa of the mice was white and a big pain and a bit pain when palpating. Here you can see that is the plain CT images. That is the X view, that's the coronal view, and also the circuit view. And you can see here, there is a lesions in the edge of the right tongue, lateral edge of the right tongue. Can you see here, the lesions is here. But you cannot, don't know, you see, seems there are lesions here because you can also to make a certain that lesions here because you already see it in clinics. But when you take the CT plan images, you cannot see exactly the border of the images. But also from the circuit view here, you are not sure if the lesions already up to the surface of tongue or not. Or also how deep of it, we don't know either. Then we take the enhanced CT images. Here is the enhanced CT images. You can see the lesions there. It becomes bright. And also you can see, seems there's necrosis within the lesions. So from the enhanced images, we can make sure that the border or the lesions, how deep of the lesions in the tongue. This is not good one, of course. This is the carcinoma of the tongue. So now we can give the comparison by these two kinds of the CT images. This one is the plain CT images, and this enhanced CT images. From the plain one, you cannot see exactly the image from the tongue. But if use the enhanced one, you can see it clearly, and also the border of it, also necrosis within the lesions. You can all see this. So enhanced CT image give us more information on the lesions. The final pathological diagnosis is the squamous cell carcinoma. So now I will move to three very common lesions within the parotid gland. One is the pleomorphic adenoma. One is a Warthin's tumor. Another is the basal cell adenoma. So I have to refer to three new concepts here, because when you use the enhanced images, especially in the parotid glands, we often get three phases of the images. One is the arterial phase. This phase of images was taken just after the injection of the contrast media. The second is the vein phase of the enhanced images. That is 60 seconds after the contrast agent injection. Another one is delayed phase, about 5 minutes to guide the image. So when you know all of this, and we move to the case 3. This one is a female, 26-year-old. She complained of mice in the right parotid for 1.5 months. This mice was also discovered by chance. At that time, he did not measure the size of the mice. The mice grows gradually, and there's no pain, no facial paralysis, no dryness of mouth and eye, no swelling of other glands, and no history of connective tissue disease. When we made the clinical examinations, we found that there was a smooth, soft, well-delineated mice in the right parotid gland, and it centered in the middle posterior side of the earlobe. The maximum diameter of the mice was about 3.0 centimeters, and there is no pain when we palpated. Also, there's no adhesion with adjacent tissues, but the mobility of the mice was not good. Also, there's no difficulties to close the eyelid, no drop of one side of mouth, no shallowness of the nasolabial groove, no disappearance of forehead wrinkle. Can you tell me why we give these informations for the lesions, for the parotid lesions? Yes, that means there is no nerve hurt. So this also a sign of a benign tumor. Intraoral examination shows the opening of right parotid was normal, not right, not swelling, no pyogenic accretions. The saliva was clear and in a good quantity. No parapharyngeal bulging. Also, there was no enlarged lymph nodes or palpated. Here shows the CT images of the lesion. The lesion was in the right parotid, just behind, you can see just behind the ramus, the posterior border of the ramus. but you cannot see exactly the border, especially for the inner side. Where is the border is not clear. Also here shows these lesions in the coronal view, and here is the second view. And also you can see the posterior rim of the ramus was deformed. That means there's a relatively long time mice. And then we got the enhanced CT images with 3 phases. There's the plain CT images. There's an arterial phase of the enhanced CT images. There's the vein phase, there's a delay phase. You can see that this is the one without enhancement media, and then you can get the arterial phase of the enhanced images. And here is the vein phase, and here is the delay phase. Is there some differences between the images? Yes, but if you look at these images, you can slightly bright of these images than the plain one, but you don't know why and how. So you have to take the CT numbers. So you see here, they will put also in the same area, similar to the same area, and you can see the CT numbers. For the plain CT images, the CT number is about 39. And here for the arterial phase is about 62. And this one for the vein phase is about 63. And for the delay phase, that's up to 86. So that means with the time going, the lesions was enhanced and the CT numbers continuously increased. So this is a sign of the polymorphic adenoma, and the final was confirmed by the pathological examinations. Polymorphic adenoma was typically in the 4th to 5th decade of life. Male to female ratio is about 1 to 1.5. Account for 75% of tumors in all salivary glands and 80% of the polymorphic adenoma is in the parotid gland. So it's a very common tumor in the parotid gland. It is a slow-growing, unilateral or symptotic mice. The dynamic CT imaging features is a continuous enhancement pattern. So the enhancement is continuously increased. So that is the feature. The 4th case is a male, 53 years old. He completed the mice in the left parotid for 3 years. This mice was also discovered by chance. At that time, it was about a peanut size. The mice grows gradually, but sometimes became smaller. There is no history of rapid growth or recently rapid growth. There is no pain, no facial paralysis, no dryness of mouth and eye, no swelling of other glands, and no history of connective tissue disease. When we made a clinical examinations, we found a smooth, soft, well-delineated mice in the left-right parotid gland and underneath, just underneath the earlobe. The maximum diameter was about 1.5 centimeters and was painful when palpated. There is no adherence with the adjacent tissues, and mobility of the mice was good. Also, there's no difficulties to close the eyelid, no drop of one side of mouth, no shallowness of the nasolabial groove, and no disappearance of forehead wrinkles. Means also that there's no facial nerve hurt. The intraoral examination shows the opening of the right parotid gland was normal. There's no right, no swelling, that means no infections. There's no pyogenic accretions. The saliva was clear and in a good quantity, and also no parapharyngeal bulging. That means the lesions is not in the deep lobe of the parotid gland. There was no lymph nodes, enlarged lymph nodes palpated. And also here is the CT images of these lesions. We can see this is the sagittal one. Also here is X view. This is the coronal view. And also here, we can see these lesions located in the inferior posterior lobe, posterior part of the superficial lobe of the parotid gland, right here. And also we can see an enlarged lymph node here. The border of this lesion is good, it's round, and we can see clearly of the border. So from the images, also from the clinical examination, we got an impression that this lesion most probably are benign tumors. And then we gave the injection of the media contrast to the patient and got the enhanced CT images. And we can see here it's plan CT images and also the arterial phase of the image. This is one phase of the enhanced CT images, and here is the delayed phase of the CT images. And then we can see clearly compared with the plan CT images, in the arterial phase of the lesions is become bright, much bright. And then compared with the vein phase, the lesions become darker and darker. So if we look at the CT numbers of these lesions, we can see the lesions is about 42 at that time, and then increasingly to the CT number to 119. And then we dropped back to 60 or 80, and then the same as the 68 here, the CT numbers. So from these CT numbers, we can also see the trends of the enhanced CT image. First is very bright and then became darker. So because this is also a typical feature, imaging feature, so we are not so difficult to make a diagnosis. This is the report of us to give these lesions. And first we give the report that there is the mice, benign mice in the left parotid gland. According to the CT images, we can make a guess that is maybe the Warthin's tumors. And then this diagnosis was confirmed by the pathological examinations. Warthin tumors is typically in men older than 50 years old and smoking. The male to female ratio is 7.5 to 1. It is the second most common benign neoplasm in salivary gland, and also it is slow growing, unilateral or bilateral, painless. This lesions is typically located in the posterior and inferior quadrants of parotid gland superficial lobe. The dynamic CT imaging feature is rapidly enhancement and rapidly washout pattern. There's no steady level displayed. That means enhance very quickly and drop down also very quickly. So that is the pattern of the Warthin tumors. Also, from the clinical work, it is also very typical because this is often found in men. You can see here, most of the people are men and also older than 50 years old. And smoking now is considered as the one of the etiology of the Warthin tumor. So if one man older than 50 years and he had the habits of smoking, most probably the lesions there is the Warthin tumor. Also, this is the only tumors that located both sides of the parotid gland. Usually the tumors are only in one side, but Watson tumor, you can find it in both sides of parotid gland. So that is also one typical character. And the CT feature, imaging feature is the quickly enhanced and quickly wash out. The third one is the female, 60 years old. He also complied the mice in the left parotid for 3 months. This mice or neoplasm was covered also by chance. And that there's no change in sizes. Also, there's no rapidly growth history. Also, rapidly is not grows quickly. There's no pain, no facial paralysis. There is dryness of mouth and eye. Also, there's no swelling of other glands and also connective diseases. When we make a clinical examination, they found there was a round, movable, well-delineated mice in the left parotid. The mice centered in the posterior and medial side of the earlobe, and was not hard and not painful when palpating. The diameter of the mice was about 1.5 centimeters. Also, there is no difficulties close the eyelid, no drop of one-side mouth, no shallowness of the nasolabial groove, no disappearance of forehead wrinkle. The intraoral examinations shows us the patient had loss of teeth lost. Also, the opening of the right parotid gland was normal. It was not right, neither swelling. Also, there's no pyogenic excretions. So that means this lesion is not the inflammatory lesions. Also from the saliva, we can see it is clear, it was clear and in a good quantity. Also, there is no parapharyngeal bulging. Also, there was no enlarged lymph nodes observed or palpated. And here shows the CT images of the lesions here. You can see there's a neoplasm in the left parotid gland. The gland was in a well-defined border. And also the density from the plan sediment is homogeneous. Then if we give the enhancement of the CT images, and then we can see it's very bright and also becomes darker and darker with the time passed. So for artery time, it is much brighter than the other two phases. It's a little similar to the last one we showed this also, but at that time, the last one is not so bright. And also we can see the border of the lesions is well-defined, If we compare with the CT numbers here, we can see in the plan CT images, the CT number is 31. This one is increasing up to 197. And then in the one phase of enhanced imaging, it comes to 121. And then in the delay phase, it's come to the 93. The CT number was 93. And what is the diagnosis for these lesions? It's a benign leucoma, right? Also, it's a benign neoplasm in the right left parotid. And then we give a diagnosis as basal cell adenoma. This was finally confirmed by the pathological examination. Basal cell adenoma is typically in men older than 50 years old. The male to female ratio is about 4:1. So from this, you can see this often occurs in male other than female. It's not a common neoplasm, but if it occurs, 70% it is in the parotid gland. Also, basal cell adenoma is a slow-growing unilateral, you can see unilateral round mass. The diameter of this neoplasm is minus 3.0 centimeters. So often it is very smaller than the other two neoplasms. The dynamic CT imaging features shows a rapid enhancement in a short time, increasing quickly up and then wash out. So I show these diagrams to show you how of the CT number changes with the time going. This one is for the pleomorphic adenoma. This is the basal cell adenoma, and this one for the washing tumors. Here, this represents the arterial phase. This is a vein phase, and that displays this is a delayed phase. You can see for the pleomorphic adenoma, it increased. Yes, it increased. The CT number increased with the time, and then got steady, and then increased continuously. So that is the feature, the CT imaging feature of the pleomorphic adenoma. If we look at the basal cell adenoma, we can see it is the CT numbers after injection of the medial contrast will be increased quickly to a very high number of CT values, and then drop on to certain phases, and then gradually drop down to a place. But if for the washing tumors, it is increased either, but also washed out very quick and going down continuously. So that is the feature of the CT values of these three lesions for the dynamic CT imaging features. Okay, now I will give two cases about the MRI uses in the clinics. This case is a female. She was about 54 years old when she came to my hospital. She complained or she suffered from the uncomfortableness in the maxillofacial region. That left maxillofacial region for 2 months. That is 2 months ago, she found that my face is not symmetrical, and the left side was bigger than the right side. There is no pain, no facial numbness, and also she had no double vision and lacrimation. There's no stiffness of the nose, and also there's no bleeding from the nose. Clinical examination shows that the face is not symmetrical. We can see a soft tissues in the left side, zygomatic and temporal region with a very ill-defined border. There was no pain when we palpated. Also, the size at that time was about 3.0 multi 3.0 centimeters. There was no difficulties in mouth opening. Intraoral examination shows that there was a mass in the posterior and superior to the maxilla tubercle. Medial hardness to soft tissues when we palpate, and the border was not clear. That means when we make intraoral examinations, we will palpate the mass, and it is not so hard, and also it was not so clear of the borders. Also, there is no enlarged lymph nodes was palpated. And then we got the CT and MRI images. We just put them side by side. And then you can see this side here, that is CT images, the bone windows. From bone windows, you can see there is the bone destruction of the skull base here, and also the deformed bone here, the temporal bone, and also the ramus was deformed. Here is the CT window of the images. I can see a soft mice in the temporal mandibular region, but not clear showing the bone destruction. This one is T1 weighted MRI image. And so you can see there is the soft tissue mice in the temporal mandibular region. And here is the T2 weighted images. From the T2 weighted images, you can clearly see the capsule. There was a capsule around the lesions, but the bone already infused with soft tissue. It cannot see the bone destructions. So that is the advantages and disadvantages of the CT images and MRI images. You can see from the CT images, you can see the bone destructions, but from MRI images, the bone destructions was infused together with the soft mice, the soft lesions. So see here and see here. From these images, what radiographic diagnosis can we obtain? It is a benign or malignant lesion. Gives a well-defined border, but with destruction of skull base. What is that? Yes, there should be a benign neoplasm in the left TMJ regions because it has a very well delineated border around the lesions, but they have some malignant behavior because the bone skull base has already been destructed. These features are also very typical for the germ cell tumor of a tendon sheath. So we give our next diagnosis, germ cell tumor of a tendon sheath. It's very typical for get both. So finally, the diagnosis was confirmed by the pathological examinations. The last case was a female, 52 years old. She suffered from pain in the right TMJ region and a maximum mouth open limitation for 3 months. When we checked the history of the disease, we found that the temporal mandibular joint has already been creaking for 2 years. And also the mouth sometimes is opening limited. The clinical examination shows that the maximum mouth opening was about 40 centimeters. And a left deviation when the mandible moved forward was observed. There was no clicking, no pain when we touch the masseter. Here is the CBCT images of a circuit view and also the contour view of the CT images. And now we can find there is something in the condyle head. What is this? Is destruction of the bone, or that is just depression of the bone by something? I don't know, because this is very clear of the border, not seems like a destruction of the bone. What is that? And also we cannot see the disc, the mandibular disc, and also soft tissues. Then we took the MRI images of the TMG, and then we can clearly see there, here is the temporal mandibular disc. It has already severely displayed anteriorly, already displayed. And then we found there's the tissue here and depressed the condyle head here. So now we know exactly this is not the destruction bone, it's just depressed by soft tissue because the disc already been anteriorly displaced and make the tissues move forward and then depressed here. So we gave a final diagnosis, anterior disc displacement without reduction. So that is all the cases I showed today. So from this case, we can get a summary about the usefulness of MRI and CT images. CT and MRI are three-dimensional imaging modalities and are very useful in outlining the borders, the area of the lesions, and showing the relationships between the lesions and the adjacent tissues. The enhanced CT imaging can provide the fourth dimension information of lesions according to the time changes. Both CT and MRI can provide soft tissue imaging, but MRI is much better than CT on displaying delicate soft tissues. That means we're good at the small tissues, soft tissue displaying. Thank you for your attention. That is all of my lecture.
Okay, Prof. Gangley, thank you.
Thank you.
Thank you for your presentation. It's very amazing and very informative for us. But first, can I ask you something?
Yeah.
I want to know why Peking University School gives name of stomatology in your school or hospital, not dentistry or not radiology, maybe. What is the name?
Yeah. It is a very good question. That is also about the discipline of our career. Because if we call it dentistry, that means it only include the jaws and teeth. And then we got our oral maxillofacial stomatology, and that means we also include the part of the soft tissues, like parotid glands, the salivary glands, and the parotid and the mandible salivary glands, and also the glands there. And also we got some tumors, the soft tissue tumors in the faces, faces part. So if we call this oral and maxillofacial, that means this part this part is two eyeballs here, down to our chin, this part included. So that is why we not only focusing on the bone and also the teeth, but also we focusing on the soft tissues within the areas. That is oral cavity. That is not only the teeth and the jaws, we are cavity, also the oral cavity including the soft tissue within it. So we call this stomatology.
Okay. I agree about that. but how about the members of the part of stomatology? Only a dentist or the medical doctor or the others?
No, we only call the stomatologists, not a dentist here. We are all trained in the school, within the department of stomatology, not in department of dentistry. So that is the difference from your schools.
Okay. Because I agree, and I teach my students about the same principle too. Yeah, because the stomatognatic system is so very interesting for us, for the dentist. Yeah, include the chewing, breathing, and the others parts of physiologists. And of course. The time is for discuss. Yeah. Well, ladies and gentlemen, now we are come to the opinion, question, and answer session. Yeah. Please raise your hand or fill in text in the Zoom chat, and don't forget to mention your name before giving opinion, question, or answer. Okay. Any question maybe?
Silakan para audiens, apabila ada yang ingin bertanya, silahkan bertanya di kolom chat atau bisa raise hand. Oke, first, ya. Oke, silakan. Oke, we will wait. Prof, ya. Based on your opinion, yeah, about the MRI and the CT, yeah, when the best time or the oh hello Menik, ya, Dr. Menik, Dr. Menik, ada yang ingin ditanyakan, Dr. Menik, any question or any opinion or the others for Prof. Gangli?
Okay, thank you. Because from the committee still with me. Now, hello, Professor Gangli, how are you?
Yeah, fine,
nice
thank you.
See you again.
Nice to see you here.
Yes. Okay, thank you for your very interesting lecture and very important for us because here in Indonesia, we still have I think it's a problem for us. We still have a lack and very limited opportunity and access for these two imaging modality, CT and MRI. We're still struggling to have access and to have opportunity to use this kind of two imaging modality. Since in our hospital, dental hospital, we still don't have it. We still have to go to bigger hospital to see or to deal with these two modalities. So I have one question actually for the salivary gland lesion. So you said about enhancement. So is it about giving the contrast media or just to do the enhancement from the images from the CT? So when we have to use the contrast media to use to injection the contrast media, or we just enhance from the images that we acquire from the CT images. Thank you.
Okay, thank you. And also for the lesions visiting the salivary glands in my school, that is the regularly that we make the enhanced CT images. That means we give the injections of the media contrast to the patient for all the patients. If we found a mice or neoplasm within the salivary glands, and then we make an injection of the media contrast to get the enhanced images, but not only the enhanced image, but also the three phases of the CT image. So we can see how it changes according to the time, because they give us the information on the lesion natures. So I just showed you the three very typical lesions, because not for all, but for some of them, it looks like that. For the premorphic adenoma, it increased and then increased and stably increased. It's not drop down and not watch out. But it is for the watching tumors. It is firstly increased quickly and then watched out and drop down and watched out of the media, that it becomes darker. So that is the character or the feature of these lesions. So from these kind of features, we can make our guess or the so-called diagnosis for the nature of the lesions. So that is why we often get three phases of the lesions. And also, when I read the articles about these studies on these kind of lesions, and usually in other hospitals, also in other parts of the world, they often use the two phases, not three. We use three. They don't use the delay phases. They only use the arterial phase and the the when phase, but we add one phase, we call it delay phase. So that is very useful for us. So sometimes according to these changes of the densities of the lesions, we can make a very close to correct diagnosis. So very useful for us.
Okay, Dr. Menik still unmute. Dr. Menik, yeah, your voice.
Your voice muted.
Can you hear me? So because from the committee automatically mute me, so I cannot unmute myself. So thank you for your explanation. So it means that it's very important to use or to just notice the phase of the contrast that has been delivered to the patient. Is that right? So because it's very for us it's a new thing about how to diagnose salivary gland lesion using the CT. So yeah, I know now that it's very important to use to notice or to observe the phase from the contrast that delivered to the patient. Okay, thank you very much. And how often the pleomorphic adenoma in your hospital? I mean, the case is how high is the frequency?
I think I think it's common because according to the articles, also according to our experience, we always say that 80% of the tumors within the salivary gland are pleomorphic adenoma. And 80% of the pleomorphic adenoma is in parotid gland.
Okay. And
another 80% is all the tumors within the salivary gland.
Okay.
Have 80% is benign tumors.
Okay.
So we have 80%. It's precise for the
80%. Also, it's very high enough for the frequency. And how about I have experienced the pleomorphic adenoma that arise in the minor salivary gland in the palatal mucous. Do you have any experience, or do you have any maybe comment for the salivary gland pleomorphic adenoma in minor salivary gland?
I don't know what is exactly want to get my opinion, because yes, there are already many tumors, different kinds of tumors, but most of them are the pleomorphic adenomas in the main salivary glands. So this the most of the tumors, if the lesions of the tumors or neoplasm is in the parotid gland, and then most probably they are the benign ones. But if they are in the salivary glands or in the other small glands,
small ones,
they're most probably the malignant. So that is difference. In the mean 3 salivary glands, that means the benign, the possibility of benign is high. But in the small glands, the possibility of malignant is very high.
Okay, so it tend to be more malignancy. Be a malignancy if it happened in a minor or a small salivary gland.
Right. Yeah.
Okay.
Yeah, that is.
Thank you very much.
Yeah, thank you. Yeah.
And I think I have many questions. Sorry.
Please. Yeah.
And how about for the MRI? do you use the contrast media also for evaluating the TMG or the disk space for MRI? But TMG, do you always use?
No, we don't use contrast medium for MRI for the TMG, because you can clearly see that they have different series of images. You can T1, T2. That is, if you can see it very clearly about the disc, and also if there's flat within the tissues, and this will give the high signal, and then showing the bright images. So that means we can get, usually do not use the medium contrast for the TMG observation.
Yeah, because I have experience to see the injection of the contrast media to the TMG location. It's very painful for the patient. Arthrography for the TMG is very painful.
But I think we use it for the plain film. When using the X-rays, plain X-rays,
for the plain film.
Don't know. Because we don't know if we cannot see the disc. Where is the disc? Firstly, we only see the bone tissues, not soft tissue. We can now decide where the disc is. So we have to inject something to show the capsules between the, also we call the spaces between the disc and the upper part of glenoid fossa, and also the condyle head. So we can see if there are spaces, and also there is the profilations of the disc. Because if there are prolification and the injections will be from the upper space to the lower space. So for the plain films, we often use the injection of the media contrast to show if there's the disc is in place or anterior display or anterior displaced. But after we having the MRI, and then we don't need to it, because the MRI images can show us very clearly about the disc, where it is anterior disc, or also in the position, or also posterior the displays. So that is.
Because the arthrography is very old technique, long time ago, before the MRI introduced to our field. Okay, thank you, Dr. Belly. Thank you, Prof. Gangli.
Okay, thank you, Dr. Mani. And next, anyone? Someone's raised hand, Dr. Irfan. Dr. Irfan, okay. Unmute, please. Unmute, please, for Dr. Irfan.
Okay, thank you for host to allow me to unmute. Thank you, Professor Gangli, and all the professor here, Prof. Hana, Prof. Harjo, Prof. Barunawati, Dr. Haris, Dr. Azhari, Dr. Mani, Dr. Remy, and Dr. Belim, and all the participants. Thank you, Professor, for your very interesting and valuable information for us. Very nice presentation. I would like to ask a few key questions related to CT and MRI. So in your presentation, there is some case presentation and examine using CT and MRI, and identify and analyze the imaging, the image finding, and also using HU value or HU unit, and also the characteristic of enhancement curve. So there were two questions related to that. First is there a standard of HU value for each lesion or each diagnosis? Because there is various diagnosis in oral maxillofacial area, and when we use CT, we can identify the HU value. So there is a standard to identify each lesion using HU value? This is the first question. The second is, in your presentation and your cases, you analyze the characteristic of enhancement curve of CT and also MRI. So my question is is the curve analysis in same case is same between curve enhancement curve analysis between CT and MRI? Is the same characteristic or this different characteristic? Okay, there are two questions for about your very nice presentation, Professor. Thank you. Sorry, I forgot to introduce myself. My name is Irfan. I am from Department of Oral Radiology, Hasanuddin University in Makassar.
Okay, thank you very much. Very good questions indeed. And also I have showed you some city numbers when I gave my presentation. For example, if that is the water you're supposed to be, and then the city numbers is the 0, and then it's supposed to be air, and that will be minus 1,000. And if it is the bone tissues, and also it's about the dense bone. If a dense bone, that is the maximum is the plus 1,000 Hounsfield. Yes, according to this, there's no exact numbers. So that just give a very wide range. You'll see in the tables I show you, maybe I can show you here.
Okay, see clearly.
So maybe you see from these tables, you can give something about the CT numbers. If that is the soft tissues, you can see they give a range that is about 40 to 80 Hounsfield. So that is the fight, that is minus 16 to minus 100. But you can see that is a range, but this is not the same. They just give the trend of the CT numbers. When you are in the practice, you will find sometimes the fight for the CT fight values is above 0, about plus 10. So anyway, they just give you an impression that this is a range for this kind of regions. So you say that if that is sinus, you know sinus filling with the air, and the sinus should be the very dark and should be give the values about here, that is the minus 1,000, should be minus 1,000, you know. If there is something inside of sinus, so that's very useful for us. Inside sinus growing up from tumors or the thickness of the mucosas, and then will make the numbers becomes like soft tissues, you know. So that maybe, so you can see that is something happen there. So you can see it. So that is how to different use these numbers. Also, the trends, you said the curves is not the same as the MRI curves. It's totally different. And then I just show you, because that curves not, you cannot find it in the textbooks, because I made this curve myself. And that is my experience about this, how it looks like, but that is not 100% correct. You know, that is just a trends. That is for most of the lesions, of the polymorphic lesions. This, you can read the papers, you can publish the paper, you can read the textbooks. They always say that they very steadily increased. Because steadily increased, the enhancement steadily increased and gave a stable increasing CT numbers. That is everyone say that, but how stable, how it gives the numbers is not the important, but they give the trends of the keeping that tendency is the most important. But from basal carcinoma and also Watson tumors, both of them give increasing CT numbers to the high numbers and then washed out. Both have these characters. But the big difference of these two tumors is that for the Watson tumors, it increased not so much as the one for the basal cell adenomas at the arterial phase. You can see, hey, increasing quickly, because I know that only according to 3 cases in very short time to present to you, you will not get an impression or any idea about it. So I made this curve for you to show how it changes. So from these curves, you can clearly see the tendency. So that is just the tendency of this. So if you got one, have a very quickly increasing to high CT numbers and then drop down, and then maybe that is the basal cell adenoma. And if that is one quickly increasing the CT number and quickly washed out and up, down here, and then most probably this is the worsening tumors. And also I already said there is many clinical features for the worsening tumors, because very typical. They're men, often in men, 7.5 to 1. So most people are men. And then the man had habits of smoking, which is considered etiology of the worsening tumors. And also there was in the posterior inferior part of the parotid. That means just underneath here, the ear lobes here, this part. So that is the most of the typical clinical features. You combining of these 2 features, you can get a correct diagnosis. There's no problem. I don't know if I answer your question.
Yeah, okay, Professor. Thank you for your explanation. So based on your experience, there is a lot of things we can get from your explanation related to your experience to identify using enhancement curve, because there is no in textbook, because based on the experience. So maybe in the future when we can collect many same cases, and then we can get this, maybe we can use a standard for if there's many cases, but just one case maybe is not proper to determine that this is the characteristic of pleomorphic adenoma. But if we have a lot of cases and the tendency is similar, so maybe we can use as a standard to identify, to make a diagnosis of pleomorphic adenoma, for example.
Yeah.
Okay, thank you, Professor, for your explanation. Thank you very much.
Yeah.
Okay, thank you, Dr. Irfan. Okay, any questions, the others? Yeah, you choose the raise hand or text the chat in Zoom chat. Okay, from Professor Gangli, based on clinical features, yeah, you have the protocol when you choose the MRI or when you choose the MRI CT, yeah, because the for your presentation, this is the kinds of soft tissue problems, yes, in your presentations and in your patient, and we based on the reasons why you choose MRI or you choose a CT directly.
That is depends on what modality we have, because at present we don't have MRI machines in our hospital. We have to refer to student, the patients to other hospitals to get the MRI images. Oh. But we have used it for the TMG, because for most of the cases, we can make a diagnosis of a correct diagnosis from the CT imaging. For example, in our regions, that is in maxillofacial regions, most of the lesions can be correctly diagnosis with the plant films. Yeah. That means if I say that is just in the bone or heart tissues, it's not difficult for us to get a diagnosis. But the thing is that we cannot exactly know the borders or where extensions are also the relation with the surrounding tissues. You know, that is the important when we make operations. So that is why we have to use the CT images to get these things. For MRIs, it only shows the soft tissues. The soft tissue images are very good, but not good for the hard tissues. For for the most part of our lesions which are within the bones is not useful. So only for those soft tissue lesions, we use the MRI images to see it. But for us, the most often happened things is TMG orthostasis. So TMG disorders is very often for us. And we cannot see much of the mandibular disc from our ordinary plain films or also the CT images because it cannot show the delicate soft tissues like disc. So we have to use the MRI imaging for this display. So that is the principle. We can't get more information because there are lots of studies to differentiate the malignant and benign tumors from the cerebral glands, but there's not so good. Actually, there's only published papers, not the very useful in clinics. You can get some references, but not exactly the same.
Okay.
You have to accumulate your own things.
Okay. But if your experience, you have the two choice to one case to imaging. You have you choose MRI and you choose CT too. You have the experience about that?
No. We have to step by step. I think firstly, when the patient comes to us, we have to make a general ordinary film for them that we have digital or film, of course, that the panoramized plane, two-dimensional plane film or digital radiograph first, and then we see how it goes because most of the lesions are within the bone, within the lesions. If we cannot, or we can put something in soft tissues, for example, we exactly see the tongue cancer. There's a lesion in tongue, and then we have to directly going to use the CT imaging, not the plain films. We only use the CT, and then we can see the borders, the extensions of the lesions, and then if there is the intrusion to the bone, surrounding bone, that is used. So for the very clear soft tissue lesions, we directly go into the CT examinations, and even if some we use them, but not so often. Rarely use the MRI for this.
Okay, and Prof. Gangli, how about the CBCT? You still use CBCT for measure or Hounsfield units?
No, there is we cannot use that. We actually not try. I don't know if you have tried, but there actually you know why we cannot get the CT numbers from a cone-beam CTs. Because the cone-beam CT has a very large range of kilovoltage used for these machines.
And maybe mistake if we use CBCT for high HU measure, maybe mistakes if you
because CT values heavily depends on the kilovoltage used in the machine. And the CBCT images is quite a wide range of kilovoltage used in the CBCT machines, from 60 kVp up to the 120 kVp. From one CBCT units to another, for example, if we use the one from akan, the imaging flux often use the CT, the kilovoltage at 120 kilovoltage. And then if you use the CBCT machine, your unit from the QR, that is Newton unit, that is about 110 kVp. But if we use the one from the Morita, it is the maximum kVp is 90. But then you can change it to the 70 or 60, lower up to 60. So there's quite a wide range of the kVps. So that not give the density. The density of the bone will not be the same. So it is quite hard to get CT values from CBCTs. So if you use a enhancement, you cannot get exactly the same thing as the CT data. So that is I think the difference, the difficult thing for CBCT. but you can try. I did not try.
Because we have any complaint from the other dentists about the measure density from CBCT. They said this is wrong. This is not actually a failure for our interpretation.
Yeah. There's only the gray values.
Yeah. Okay, our all audience, you have any question? Untuk semua peserta, apakah ada yang masih ingin ditanyakan? Oke. Kalau misalnya memang tidak ada, ya, thank you for our big brother, Professor Gangli, for
thank you.
Your very interesting presentation. Yeah. Once more from the chat room. Okay, I read that. Hello, Prof. Gangli. I'm Putri, resident from Pajajaran University. I would ask how to differentiate malignant and benign lesion on MRI. Thank you, Prof. Repeat again, maybe.
Frankly speaking, I don't have much more experience on MRIs for the differential diagnosis between benign and malignant. But if you use different kinds of serious MRI imaging, sometimes you can differentiate. It's not, sometimes for some lesions, it's easy, but not for all. Okay. They have to follow at the principle. That is principle, if the borders, if that is well or defined or ill-defined, that is most important. But sometimes, the mice in salivary glands is very different from others. If they have very good borders, but they will give a low-grade malignancy, like the cellular carcinoma. That is the one that is most often occurred in the parotid gland, the low-grade thing. Okay, so okay. It's difficult. For me, it's difficult. Not easy.
But maybe next time, next year, 2-3 years, next year, we have say Dr. Irfan say before. Maybe we can have the standard for every case of the failure, or maybe density or the other part of MRI or for CT, based on a lot of research next time.
Yeah.
Okay.
Yeah. That is all the researchers are searching for such standards and publish lots of papers on it. So we can read that and found that it's still, because I think maybe different from machines or different from the method used, is not a very, very equally cited or useful. So maybe from yours, that is why I give my experience here. But if you use my experience, maybe sometimes it's right, maybe sometimes not right. But actually my experience from my clinical work. And then if you accumulate your own experience, then maybe a little bit different. But I think the trend is the same.
Yeah, China, Indonesia, almost the same. Have a lot people. Yeah. Lot of people, lot of pathologic condition, and a lot of all. Yeah. Thank you, Prof. Gangli. Ada any questions? If we don't have any question, saya kembalikan pada moderator. Well, ladies and gentlemen, finally we are come to last agenda, and thank you for your attention. And for Prof. Gangli, thank you again for your presentation. Okay.
Thank you.
Okay. Waktu saya kembalikan kepada MC. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much, Prof. Gangli and Dr. Bailey, for the enlightening presentation about application of CT and MRI in oral and maxillofacial radiology. I wish there will be another lecture session in the future, or maybe another collaboration with research professor. Now, before we wrap our session up today, there will be certificate submission to our speaker and moderator that will be given the head of study. Program Dental Maxillofacial Radiology Universitas Pajajaran, Dr. Zakia.
So, Gangli, on behalf of the faculty, I'm representing the dean here. We would like to say our gratitude to you. Thank you for coming virtually from China. And as a for Dr. Belly first.
Yeah, thank you.
Thank you, Dr. Belly, for hosting the session.
Yeah.
It was such an interesting discussion session, Dr. Belly. Everyone engaged very well. Thank you. We're waiting for the committee to share the e-certificate for.
And now for the moderator.
Okay, this is for Professor Gangli. I haven't virtually expressed the certificate to him. I think there's a bit of technical problem here.
Back, slide-nya back tadi, next previous, ya.
I see.
Ini disekaligusin dua soalnya. Buat admin di back lagi ya, previous slide, please. Itu next, right? Nah, satu lagi. Nah, ya, SP.
Right. Please allow me to repeat again. Professor Gangli, thank you very much for the amazing lecture. And we hope this event will trigger further collaboration between Peking University and us. Looking forward to lecture, Professor Gangli. Thank you.
Thank you. Thank you for your nice preparing for these lectures, and thank you all here to be with me for my lectures and talking about the MRI and CTs in radiologies. I hope you all really enjoy my lectures, and I hope I will meet next time.
We all do. Hopefully we can meet soon offline next time. Thank you.
Thank you. Thank you all.
Well, ladies and gentlemen, now we move the photo session. Our operator will take the screen capture. So please turn on and open your camera. The screen capture will begin in 1, 2, 3. Thank you so much. Okay, next page. The screen capture will begin in 1, 2, 3. Thank you very much for your participants. It is the end of our live session today. I hope we can meet in the next visiting lecture. Thank you so much for Professor.
Thank you all. Thanks.
Thank you so much, Professor.
Okay, thank
Thanks.
you.
Thanks.
Thank you,
Professor
Professor
Kangli.
Kangli, Dr. Bel.